A systolic ejection murmur originating in a narrowed pulmonary outflow tract is typical of tetralogy of Fallot. The large ventricular septal defect does not produce a murmur because the pressures are equal in both ventricles. Listen to the murmur of tetralogy of Fallot. This murmur is usually heard best at the third left intercostal space. Tetralogy of Fallot consists of 4 components. Number 1, pulmonary stenosis, which can be valvular or subvalvular. Number 2, a non-restrictive ventricular septal defect. Number 3, an overriding aorta that receives blood from both ventricles. And number 4, right ventricular hypertrophy. This disease continues to be the most common cause of cyanotic heart disease after infancy. What is unusual about this ejection murmur is that its intensity and duration are inversely related to the amount of obstruction across the pulmonary outflow tract. As the pulmonary obstruction increases, the murmur becomes shorter, softer, and peaks earlier in systole, reflecting decreased pulmonary flow, while the large ventricular septal defect allows more shunting of blood to the left ventricle. In the past, a repair of tetralogy of Fallot began with a right ventricular incision, through which a patch closure of the ventricular septal defect was performed. Followed by the placement of a transannular patch across the pulmonary valve. For many patients, this transannular patch results in significant pulmonary regurgitation. As a result, many repaired patients have both a systolic murmur of residual pulmonary stenosis as well as a short diastolic murmur of regurgitation. Listen to the combined murmurs of pulmonary stenosis and regurgitation. I will start with 3 normal beats and then add the systolic murmur and then the diastolic murmur. Notice the widely split second heart sound. In current surgical practice, these repairs are often done via the right atrium and/or the pulmonary artery, thus avoiding a right ventricular incision. Listen once again to the murmur of combined pulmonary stenosis and regurgitation, and notice the widely split second heart sound common in these patients. Long-standing pulmonary regurgitation puts a strain on the right ventricle, which can result in dilation and dysfunction of this chamber. Replacement of the pulmonary valve via open heart surgery has been the treatment for this problem in the past. Recently, it has become possible to replace the pulmonary valve via a percutaneous route, thus avoiding the need for open heart surgery. These tissue valves are relatively new, and long-term results are still pending. Listen to the murmur of pulmonary stenosis and regurgitation in a patient's status post-operative repair for tetralogy of Fallot. Over the last 4 decades, Advances in surgical treatments have dramatically improved the survival of patients with Tetralogy of Fallot. In fact, survival to age 35 is now 85% for those with successful operative repairs. Following successful repair, some patients may have a pansystolic murmur due to a residual ventricular septal defect around the patch. Listen to the murmur of a residual septal defect. Patients with repaired Tetralogy of Fallot are at risk of arrhythmias and sudden cardiac death. Several studies have shown that when the QRS approaches 180 milliseconds, patients have an increased risk of ventricular tachycardia and sudden cardiac death. ICDs are available for those at the highest risk. Listen once again to the combined murmurs of pulmonary stenosis and regurgitation. In following adult patients with repaired Tetralogy of Fallot, it is recommended that they have regular examinations, including EKGs, echocardiograms, and Holter monitoring when appropriate. Cardiac MRI is considered the gold standard for evaluating the need for pulmonary valve replacement. In summary, survival following repair of Tetralogy of Fallot has improved dramatically in the last 4 decades. However, even after successful repair, patients are at risk of late sudden death when their QRS approaches 180 milliseconds. Listen once again to the murmurs of pulmonary stenosis and regurgitation.